Thanks, Subhash.
Who says that you can't handle technology? I think you just refuted those claims, and they've shown us great work how in your hands things work very beautifully. I think our session is moving so well, and even Manish is smiling. I can see him. Is that we are all agreeing with each other, and I'm going to try and put a wrench in this and try to ask to Nick and then go to Sahil. We are hearing a lot on the chat screen, and uh, and also on the in a general conversation with colleagues, that people are viewing shockwave and atherectomy devices as equivalent, or sometimes there is little confusion where and when one works. So Nick, a question to you, and it's not an easy one, I know, and there's not much data. Where do you see specifically the applications of shockwave versus one of the atherectomy tools? Does the degree of calcium, IVUS imaging, as you said in the past, the length of the calcium, inability to protect, what are your drivers to determine when you would use one or the other? Or you just view them as totally different technologies and both need to be used simultaneously?
Yeah, that's a great question, Subhash. I mean, first, Chris have illustrated very nice case of iliacs, for instance, where the shockwave works very well, and atherectomy may not be the best option there. In fact, because of the risks involved of using atherectomy in iliacs. So that's a place where you find a lot of calcium, for instance, where shockwave probably will be a first line in my world. And the other thing is when you look at vessels like the common femoral artery, the shock waves seem to be really working very well there. We've done many cases. In fact, we're piling up our experience for a little over 90 cases right now. So we're going to be presenting that soon. But they work very well. They work very well in that situation. One of the things is it's not necessarily these are technologies which are competing with each other. As you know, we just published something on combining them. Combining atherectomy with shockwave in about, I think, 28, 29 cases that we did. And it was very impressive, the acute procedural results. We think that atherectomy probably will take care of a lot of the superficial, severe calcium, may not be able to handle, very well the deeper calcium, and that's where shockwave complement what atherectomy can do. So having this combination therapy has not really been looked at in a randomized fashion, but at least in some observational data seems to be very promising, and I think we're using it more often right now. So again, there is plenty of room for these two technologies to work together in that situation.
Thank you, Nick. You all realize that our program is being looked at and listened to by fellows, by interventional fellows, and also early career. I want to break it down. So Nick highlighted two areas where shockwave would be beneficial. One definitely is the intrapelvic areas and vessels where atherectomy probably shouldn't be used, or very, very rare circumstances, but not indicated certainly for this audience and our discussion. Sahil, and also you mentioned common femoral. Sahil, can you provide some other key features that allows you to pick one of these technologies over another?
Yeah, so Subhash, thanks for the question. We actually had the ability to get the core lab data from Shockwave, and we're able to meta-analyze from different vascular beds. And the interesting thing, the paper was published in CCI earlier this year, but the interesting thing from the core lab data was several things. One was that irrespective of the type of calcium, either concentric or eccentric, the Shockwave device provides a similar luminal gain, relatively high luminal gains, increasing vessel diameters from nominal, to say 75% stenoses to 25% residual in virtually every case in every vascular bed. We actually created a dimensionless index to see if we could compare, was it better in the iliacs or the fempop or the below knee segments? And to our surprise, it was almost identical across all three beds. So that was interesting to me. In fact, there was a trend towards having better luminal gain in concentric versus eccentric lesions. It's the first device that I'm aware of that works better the more calcium there is. And so to me, I think it allows me to sort of come up with sort of an algorithmic approach in that if I'm working in large vessels, and we know that the current available size is only as big as 7 millimeters, but for large vessels in the iliofemoral segment and up to the CFA, the Shockwave device provides a relatively safe and quick and effective approach for both intimal and medial calcification. The case that Chris showed live at TCT brought the house down, the kissing shockwaves. It was a tremendous demonstration of what had previously been an area that was very, very fraught with risk. And he, of course, as always, did it elegantly and safely with a beautiful CRAB type of result. I think in the FemPop segment and below the knee, there's more data that needs to be acquired. But I think the big issue is sort of what Chris alluded to, which was the embolic risk. When you have heavy intimal calcification and you do long runs of a debulking technique, the risk of emboli increases. And if you have difficulty protecting for emboli or inability to protect for emboli, I think then the shockwave provides you a nice alternative. So I sort of view it in that way. It would be great to combine all these technologies, but we'll bankrupt this healthcare system. And so we need to, again, I would reiterate what Rob said. We need head-to-head, prospective, randomized trials to really answer these questions.
Thank you, Sahil. We have a few more minutes on this very interesting topic, and I'm going to ask for some rapid-fire responses from Karen and Rob and then Matt regarding any additional points they would like to mention regarding the selection of shockwave and versus dedicated atherectomy tools. I think what I'm trying to get to is that in your own practice and experiences, are certain situations pre-select one technology over another, and within atherectomy, if there are specific situations, so that our fellows and early career faculty and trainees can actually take something finite back from this discussion. So Karen, you first, Rob second, and then Matt, rapid fire responses if possible.
Sure, thank you. So I think several things come to mind. So when I look at that common femoral example as a surgeon, I'm wondering, what does this look like afterwards? So I think IVUS imaging would be great there, just to make sure we can leave with a good feeling and not just go by luminography. Another one is in the tibials. So a patient with poor outflow and really no good options, that's a good location for considering atherectomy or additional more aggressive maneuvers. So I think those two in general would be good things to keep in mind.
Thank you. Rob?
So I think that we need to be, very conscious about what the role is of, any drug-based delivery platform and what role, if any, atherectomy has for that. We've been sort of hemming and hawing about atherectomy DCB all morning. Is there a role for atherectomy and DES? We don't know. There's not enough data, and I'm going to echo Sahil's previous points. We really do need to do much more randomized prospective data to answer these questions.
Thank you. Matt, you are on next, but as a prelude to your talk, are there any specific criteria that you use to select one technology like shockwave over a specific atherectomy tool in your own practice?
Sure. Thanks for the question, Subhash. I think the major issue with atherectomy, particularly for below the knee segments, as Sahil pointed out, is distal embolization. And so I think lithoplasty in my practice has increased. I think it'll be interesting to see how reimbursement shakes out with the balloons, and I think we might see wider adoption of use, but I do feel that bundled payments and those implications of cost are going to be really front and center in our decision making going forward.
Thank you. Thank you, Matt. You're way ahead of your years in terms of maturity and selection. So I'm going to probably in the panel discussion ask Mehdi and Sahil to take this issue a little bit further about the selection of a type of stent. We can make different arguments there, but I'm trying to bring some debate to this very, very congenial discussion.